Lotheissen repair is a transinguinal high approach for femoral hernia where femoral canal is accessed through the inguinal canal and repaired from above where conjoint tendon is sutured to Cooper's ligament. Consider this as a right femoral hernia model. Inguinal ligament is present between pubic tubercle and anterior superior iliac spine. In femoral hernia, swelling appears below the inguinal ligament lateral to pubic tubercle. Transverse skin incision is made approximately 2 cm above and parallel to medial half of inguinal ligament, similar to standard inguinal hernia incision. Subcutaneous tissue, campus and scarpa's fascia are divided to expose external oblique aponeurosis. The external oblique aponeurosis is incised in direction of its fibers starting from external inguinal ring to pubic tubercle. Now just for demonstration, external oblique aponeurosis is taken out. Fascia transversalis forming floor of inguinal canal and round ligament lies over it. Round ligament is mobilized and retracted upwards to expose posterior wall of inguinal canal. Transversalis fascia is incised from deep inguinal ring towards the pubic tubercle. Peritoneum identified and hernial sac is identified as it protrudes through the femoral ring into the femoral canal. The hernial sac is carefully dissected, free from surrounding femoral sheath tissues. If hernial sac is tight, lacunar ligament forming medial border of femoral ring may be incised to release constriction. We can see the femoral ring bounded anteriorly by inguinal ligament, posteriorly by Cooper's ligament, medially lacunar ligament and laterally by femoral veins. The sac is open and contents are visualized. If the contents are gangrenous, this inguinal approach provides necessary access to perform resection. In such cases, peritoneum is open to access the contents. If the contents are viable, it is reduced directly and hernial sac is rotated and transfixed at the neck. Excess sac is cut, hemostasis checked and allowed to retract. Interrupted sutures are placed between Cooper's ligament below and conjoint tendon formed by fascia transversalis and internal oblique above. Subsequent sutures are placed laterally without tying the knots. Non-absorbable sutures are used. In lateralmost bite, to avoid compressing or injuring femoral vein, the suture is placed between inguinal ligament and conjoint tendon. This is called transition suture. After placing all the bites, sutures are tied approximating the conjoint tendon down to the Cooper's ligament, thus blocking the femoral ring. Suturing the transversalis fascia and conjoint tendon to the Cooper's ligament creates significant tension. So, releasing incision is often made on anterior rectus sheath. This reduces tension and prevents cut through of tissues. In Lotheissen repair, femoral ring is not closed directly, but conjoint tendon acts as a screen between peritoneum and femoral canal opening, thus prevents recurrence. Round ligament is replaced in its anatomical position. External oblique aponeurosis, subcutaneous tissue and skin closed in layers. This completes Lotheissen repair of femoral hernia and is mainly used in suspected cases of strangulated femoral hernia. Key steps include transinguinal incision, high approach, separation and ligation of sac, and repair by suturing Cooper's ligament to conjoint tendon. Thank you.